Thanks for having me. My name is Marina. I'm a fourth-year nursing student, so I'll be graduating in December. And I struggled with an eating disorder for about 7 years, and thankfully recovered and have done really well. And I told myself that when I recovered, I would just try to educate people more about eating disorders, try to raise awareness. And it's great that you guys came out because you guys are in the healthcare field. So prevention, identification, and treatment really starts with you guys, because if you guys can't identify it, the general public will definitely not be able to. Let me just say that these smart board things are like the greatest thing in the world, because I feel so smart. Again. So I love food puns. Eating disorder topic is really difficult to talk about. A lot of people feel uncomfortable, so I'm full of food puns, lots of good stuff. And food is everywhere. It's part of life, it's part of social life, it's part of like the way we keep our bodies physically strong. Like, I mean, how many people came here because of the free food, right? Like, okay, I know you came for me too, but free food, right? Like, everyone comes for it. So today we're going to talk about education for medical healthcare professionals. Education, I like to just make it ED for eating disorder. So, our first food pun, just to break the ice. So what did the grape say when it was crushed? Nothing, it just let out a little whine. Get it? Like, oh. It's cute. And this is my website. It's my blog, anorexiarecovery1.blogspot.ca. And for those of you who are interested, I did bring my book. So if anyone's interested at the end, you can certainly purchase it. It's $20. And I wanted to say, today is National Chocolate Day, okay? Did anyone know that? No, right? Yeah, I love chocolate, so happy National Chocolate Day. So my story, I know, right? It's so cute. So, do you want to talk about it? No, it's not your problem. I never used to want to talk about my eating disorder. For a long time when I was sick, I kept it a secret because it's very difficult to come out and, say, I'm scared of gaining weight or I don't want to eat. And a lot of times people just don't understand that, especially in society today. There's a lot of fat shaming. There's also a lot of shaming just about bodies in general. You're never the perfect size. You're either too big, you're too skinny, you're not muscular enough. And that could be for females and for males. And so like I said, I started struggling with an eating disorder probably when I was about 8 years old. I started to just get feelings that I was fat, that I didn't look very nice. And I started restricting just to lose weight. I was a little bit on the chubbier side when I was younger. And I just started looking around at other girls around me, and I felt like I was different than them. I felt like I was bigger. And I thought, well, what could I do to lose some weight? And there's no shortage of, diet advertisements or whatnot. People say, drink more water, eliminate sweets. So that's what I started doing. And I found that I lost 5 pounds when I was about 14 years old. And I felt so happy with myself. So I was like, well, if cutting out desserts makes me lose 5 pounds, what happens if I cut out more and more and more? And that's when it really started to get ingrained, I guess, in my head. And I remember a big turning point for me. You guys can come here. I don't care. Yeah, I remember I was in grade 8, and I had the biggest crush on this boy. It was like my first real crush, and when you're a teenager, you're like, oh, does he like me, does he not? You're in that phase. And I remember asking one of my friends to go up to ask him, like, oh, when you're a teenager, you go, like, ask him if he has a crush on me. So she went up to him, and she was like, do you have a crush on Marina? And he's like, no, I could never like her because she has fat thighs. And she came back and she told me that. And I remember hearing that and just feeling so bad about myself and thinking, like, oh my gosh, like, I'm never going to end up having like a boyfriend or ending up with someone because I have fat thighs. And from that moment on, I vowed to lose my thighs, to lose weight, everything. And it really started to, I guess, get ingrained in my head. Things, like, I lost weight, but it really got bad in the first year of university. I don't know why. I was living at home. I guess it just spiraled out of control in my head that way. And I really began to restrict my intake. I was eating probably about maybe like 1 cookie in the morning and 1 cookie at night, and that's all. And still, going to school, studying nursing, everything. So obviously I lost weight very quickly. And by April of my first year of university, so 3 years ago, I was 55 pounds. And I was very sick. I was not able to walk. I was dragging my feet around me. And I went home one day, my last day of exams, and my parents, oh, by the way, this is my mom recording me with the iPad.
Hi.
And this is my dad, Dr. Nagy Abdelmalik. So I pretty much went home, and my mom said, there's no way you're sleeping in the house tonight. You need to go get help. And I was like, no, I'm going to start eating, which is so typical of patients with eating disorders because they just don't want to eat. And it's very easy to say, I will start eating, but to physically do it is a totally other story. So my parents, bless their souls, they were obviously so much stronger than I was in the eating disorder was, they pretty much insisted that I go to the emergency room. And I didn't want to, and my dad finally pulls out, well, if you don't go, then we're going to Form 1 you. And I was like, you guys know what Form 1 means, right? You say you're not capable, the doctor signed the form, and they force you to go to the hospital. And I was like, there's no way you're going to do that. And he's like, yeah, we're going to. So my family doctor shows up, and he's like, if you don't go, I'm sorry, we're going to have to form you. So I was like, So I go to the emergency room, and in my head, I'm like, okay, this is what I'm going to do. I'm going to tell the emergency room nurses, I have no idea what my parents are talking about. Bring me a meal here, and I'll eat it in front of you, and they're going to see what I'm going to eat, and all will be well, and I'll go home, and life will be good. I went to the emergency room, and my parents said, oh, she's not eating. And the nurse says, okay, let's put her on a scale. And she put me on the scale, and it read, I think it was 53 pounds. And the nurse just took one look at me, and she paged the doctor. She's like, we need to get this girl in stacked. And I went in, and again, I thought it would just be a couple of meals, I would be fine. And it obviously wasn't like that. We ran blood tests on me. My BUN creatinine, so kidney function, were sky high. Kidneys were failing, and I got admitted. Then on the medical floor, things took a downturn. I woke up 2 weeks later on the medical floor, completely short of breath, unable to breathe. They found out that my body was just so thin that it had started eating itself for energy. So, your glucose level runs low. What do you go to next? You go to protein reserves. So my body had eaten away at my diaphragm, so I was not able to breathe. So I was sent up to the ICU. I was intubated on a mechanical ventilator. And shortly after, they found out my kidneys had completely failed. No urine output, nothing. So I had to be on dialysis for 24 hours a day, 7 days a week. And because that, my heart was failing, it was just a mess. So I was sedated for that period of time just because it was too much for my little body to handle. So for a long time in the ICU, I was completely unaware of what was going on around me. And when I did wake up, kind of from the medications wearing off, everything was pitch black. I was tired, I was weak, I just wanted to die. And I remember thinking like, oh my gosh, I'm going to be 19 years old and I'm going to die from an eating disorder. And it was horrible. Probably a month after, I woke up in the ICU. They kind of shook me awake, and they said, okay, I had an NG tube, by the way, feeding me through there. They told me, we think your diaphragm is a little bit better now. You've gained some weight. We're going to try to take the tube out. And they did. They took the tube out shortly after the dialysis was stopped, and I was alive, and I was okay. And from that moment on, I realized, okay, something's got to change. I have to start eating because there's no way that I'm going to ever be able to graduate from nursing to do anything if I continue in the eating disorder. And that was obviously easier said than done. I went home. I was on the eating disorder wait list for an inpatient program. They called me 3 weeks later, and I accepted and I got in. The program helped me stabilize my meals, for example, 3 meals and 3 snacks. After a while, I didn't feel like the program was helpful. You'll find that patients with eating disorders could be very competitive with one another. Just, like who gained the most weight, who didn't, triggers like exercising or whatnot. Basically, I signed myself out of treatment, out of the program 3 weeks later, but promised myself that when I went home, I would eat and I would do well. And again, easier said than done. It was the hardest thing I've ever done, forcing myself to sit down and eat 3 times a day meals plus snacks 6 times a day. Seeing the weight go up on the scale, feeling like I was physically getting bigger, and just dealing with the comments, like people would say, oh, you look good. And for me, that didn't mean I looked good, that meant I was fat. But I did it, and 3 years later, I'm doing very well. Meals are no problem. Weight is right where it should be. Advocating for eating disorder treatment. I have my blog. I wrote a book just about my experience with the eating disorder, how to support somebody with an eating disorder, what healthcare professionals and just the general public need to know about eating disorders in terms of prevention, identification, treatment. And it's doing very well. I have my blog, I go and give talks, and life is very good. So my hope is for you guys to take, whether it be from my blog, from this talk, from the book, and to really use that in your practice, even just in your education, and advocating and helping other people understand more. Because there's a big knowledge gap, unfortunately, around eating disorders in general, whether that be in treating it and even just knowing it, knowing what the signs and symptoms are, how to even approach a patient. When you have a patient with an eating disorder, do you have them on antidepressants? Do you feed them? If they're resistant to treatment, do you just step back? It's really difficult. So I hope that you guys can benefit from that. So what is an eating disorder? Me so hungry. Obviously, me so soup. I'm so hungry. So people with eating disorders, obviously, it's a restriction of food intake. And I think one big thing that I want to impress on you guys is someone with an eating disorder doesn't necessarily have to look emaciated. Someone with an eating disorder can be very well at a normal weight. They might even be overweight. They might be underweight. But weight and BMI generally is not an accurate predictor of health, just because you might be more muscular and your BMI will be higher. You might have a genetic predisposition and your BMI is a little bit lower. So BMI and weight, they can help you, but they're not the end-all, be-all. A resistant to eating and gaining weight, and just the fear of being fat and feeling like your weight is not where it should be, and actively trying to control that. Generally symptoms or signs that someone might be struggling with an eating disorder. It is a mental health issue, and I want to point that out. It is obviously a physical issue, but under the DSM criteria, it is categorized as a mental health issue, and that's something that can help you, I think, maybe empathize with patients more, to realize that this really isn't under their control. They're not trying to be difficult. They're not trying to sabotage their lives, to lose weight and die. The fear factor doesn't always work with them. If you tell them, you're going to die, they might say, oh, that happens to everyone else with an eating disorder, but not me. Because it's true, right? Some people with eating disorders might very well not have organ damage. Some people might. So just keeping an open eye and recognizing that every patient with an eating disorder presents a different way. And I think that's pretty much, I guess, generalizable to anything. I mean, someone with diabetes might have like sky-high glucose levels, but then their hemoglobin A1C is like totally under control and they're not on metformin. Then someone with type 2 diabetes might just not need metformin, they might need insulin. So it's just keeping an open eye that people present differently. So types of eating disorders. So there's anorexia, where there's just totally restriction of food intake. There's bulimia. Bulimia could be binge, so you eat mass quantities of food in one period of time. There could also be purging associated with it, so use of laxatives, use of diet pills, use of exercising, cathartic measures to make the person vomit. There could also be EDNOS, which is eating disorder not otherwise specified. This is typically a diagnosis that's given to someone who doesn't meet the criteria. So if you open the DSM, it says for anorexia, the weight is, I think, less than 85% of what the normal weight would be for someone. So for example, if someone is actively restricting, but their weight is not less than 85%, they would fall under the EDNOS heading. Recently, there's been a change in the diagnostic criteria for eating disorders. Before, it used to be for not for females, just under the general anorexia, it would be amenorrhea, so the absence of 3 consecutive periods in a year. And they took away that criteria because it didn't apply to males, obviously. And the second thing is that a lot of people with anorexia or even bulimia will still have their period, their menstruation actively. So it's not an accurate indicator. And I think that's something I want you guys to take away from the DSM criteria as well. I mean, it's great that there is a criteria, but I mean, if someone is, not 85%, but they're a little bit higher than that, but they're still actively restricting and still have an intense fear of gaining weight, you could diagnose them with anorexia. Just because it's not like textbook, it doesn't mean that they're not diagnosable, I guess, per se. And I think that's something in the healthcare field that everyone needs to move away in. Like, in nursing, I don't give diagnoses, but if there's a patient with, say, I don't know, they look like typical congestive heart failure, and they have fluid retention and edema and everything, but they don't hit textbook diagnosis. Does that mean we're not going to give them like a bolus of Lasix if they're in pulmonary edema? We probably would, even if they're not typically diagnosed as congestive heart failure. So good luck. So good luck diagnosing someone with an eating disorder textbook. It's hard. It really is. And good cheese. So there are a lot of causes for eating disorders. There's not a one specific thing that we can say, okay, it's because this person had a mother with anorexia nervosa, for example, or this person was bullied a lot when he was young, this is why he developed an eating disorder. It's really multifactorial. So things like genetic predisposition can contribute to it, things like bullying, things like societal pressures, peer pressure, advertising, just being exposed to a stressful situation. But it's not a stage that someone goes through. A lot of people think, oh, my teenager is just trying to eat healthier and she's going to be fine after. Or he's just trying to get muscular, he'll be fine after he works out at the gym. And eating disorders aren't phases that someone goes through. If someone really has an eating disorder, it's going to be something that needs to be identified, treated, and stopped really dead in its tracks. It's not hereditary, so for example, if someone's sister has an eating disorder, that does not mean automatically that the person is going to have it, but definitely genetic and family factors do interplay with that. And contrary to popular thought, males are affected too, and that's why I put that, excuse me, so males can get eating disorders as well, and that's something that we're seeing a lot in statistics and in the practice in the healthcare field. A lot of males are being diagnosed or being kind of screened as having an eating disorder, which is something you guys need to have on your radar as well. Just because someone is a male and he works out and he's trying to get muscular, you might think, no, he can't have an eating disorder, it's just a man thing, he's trying to get strong. But they can, and that's something that we need to take care of in the healthcare field as well, because males typically have a harder time admitting to the problem of eating disorder because it's been labeled so much as being a feminine problem, so just keeping that out. So questions to ask, so just kind of things that should make your light bulb kind of go, ooh, I think this person might have an eating disorder. Do you worry about your weight? Are you satisfied with your body? Explain to me what a typical day of eating looks like for you, whether that be breakfast, lunch, and dinner. Surprisingly, a lot of patients, they will tell you honestly, oh, I don't really eat this, or I eat this. However, some people will make up a typical day of eating. So in that case, it is difficult. But thinking, are you satisfied with your weight? Do you exercise excessively? Even when, there's another event and you really want to go to it, do you make time out of that to go exercise? Are you able to go out and enjoy food with your friends? Do you feel like you're holding back on that and not able to enjoy it as well? Do you diet now or in the past is a big one. Even something like a casual diet, like, oh, I'm going vegan. If you're vegan because, that's a religious thing or that's like a very strong, firm belief, that's fine. But unfortunately in society today, every day I think I read like a new BuzzFeed article about like why milk is bad for you or why veganism is the best way to lose weight or stay healthy. And we know that everything in moderation is the healthiest way to go. So be aware of these little diet things that can pop up in patients. The scoff is a good tool to use. It's on the next slide. And just remember that when you're talking to someone about the eating disorder symptoms, it's really important to be non-judgmental because it's difficult to admit that you have these problems. It's difficult to say, yeah, I do kind of feel fat, or yeah, sometimes I do exercise a bit excessively. So being non-judgmental, being supportive, and I'm sure you guys, like probably at Mac, like person-based, problem-based learning. So open-ended questions, therapeutic communication is the way to go. And remain calm, because if you're not, they probably won't open up. So the next slide is the scoff tool. This is something that was made in London, I believe, but it's a pretty good way to kind of get an idea if someone might be struggling with an eating disorder or not. So if each question, yes, is 1 point, and if you score more than 2 points, there's a risk that they might have anorexia or bulimia or eating disorder. So the first one for S, do you ever make yourself sick when you're uncomfortably full? C, do you worry that you have lost control over how much you eat? O, have you recently lost over 1 stone, which is 3 to 4 pounds, in a 3-month period? Do you believe yourself to be fat, even if people say you are too thin? This question, do you believe yourself to be fat, is where I would probably stop, because some people might not get, oh, you're so thin, but they still might be struggling with an eating disorder. And would you say that food dominates your life? So if you think about what I just went through, it kind of makes sense, right? Like if somebody answers yes to more than 2 of these questions, like when I was ill, I probably answered yes to a couple of them, and yeah, it would be just a quick way to see if someone might be struggling with not. Obviously, if someone has more than that, you would delve deeper. But even if someone answers no to all of them, but maybe yes to something like, do you believe yourself to be fat? That would still be something to probe deeper. If somebody answers no to all of them, but has lost more than, has lost the stone in the 3-month period, obviously, you'd be thinking of all the other things like, I don't know, lupus or rheumatoid arthritis or whatever else, but just keep it into mind. And that's something that I want you guys to take away from. Not everyone who struggles with weight loss or food will have an eating disorder, but it's always better to err on the side of caution with eating disorders than for it to pass by unnoticed. So there are brain changes that happen in patients with eating disorders, and I usually don't put this slide to the general public because if I throw things like neurotransmitters and dopamine and serotonin, people aren't going to get it. But I'm pretty sure you guys have some exposure to it, so I'll go through it quickly. So there's been a link with patients with eating disorders and certain neurotransmitters. So if you guys are familiar with dopamine, it's the reward neurotransmitter. And they found that patients with eating disorders, when they eat, dopamine isn't released like the general public. So that kind of helps you, I guess, to understand why it's so difficult for patients to eat. It's not just they have a fear of gaining weight. There's actually neurobiological changes that happen inside of the patient with an eating disorder. And that's something to keep in mind. Now, this does open the door for people to say, should we medicate? Medicate, medicate, medicate. And in some cases, medication might be indicated if someone has severe anxiety or severe depression. Definitely, certain medications can help them get over those feelings, maybe help them reframe their thoughts and be able to eat. But just because we're in the medical field and we're physicians and we're nurses, sometimes there's a tendency to go to medications right away. And in a lot of the cases, I'm sure you guys have noticed, medication should be a part of treatment. It's not the end-all, be-all. So there's things like lifestyle changes, there's things like therapy, there's things like support that we need to keep in mind. There's also changes in hunger and fullness cues, and this is a big reason why patients with eating disorders are not able to always eat spontaneously. So when we're treating someone with an eating disorder, we have to tell them, you have to eat by the clock. It has to be a set time, whether you're hungry or you're not. Because reality is they're never going to feel hungry. Even if they do feel hungry, they're going to suppress those feelings of hunger, whether that be with distraction, with just forgetting about it. So just telling them, eat when you feel like it is not going to work. There are also changes in white matter in the brain, which could be the association area or just a result of impaired fat intake, because we know fat intake is really important for brain functioning. So why this is important is it's potentially reversible with treatment, which I think is a really positive thing. You probably won't tell the patients that you have a decrease in white matter in your brain, but it's positive just for you to know that just because someone is struggling with an eating disorder, it doesn't mean that they're going to get progressively worse and nothing is going to be reversible. In fact, the brain changes are potentially reversible with treatment. So I think that's really positive just to look at. And this is just a cycle of what happens in someone with an eating disorder. So, they restrict intake, and then you might think, great, they've lost weight, they're going to stop. But that's not the way it happens. Because it is a mental health problem, that just starts a cycle. They've lost weight, great, I've lost weight, I can restrict more. I restrict more, maybe I get a little hungry, I eat something because I think that I'm going to die if I don't, but I eat something and I feel so guilty, I vow to never eat again. Restrict even more. And it just goes on and on and on. And that could be with anorexia, with bulimia, it might be the same thing, but I purge, I feel guilty, but now I'm hungry, so now I binge. But as soon as I binge, I feel so fat, I'm going to purge again. And it happens all over again. So it's really a cycle, and if we don't intervene somewhere, it's going to keep going and it's going to get worse, which is definitely what happened in my case. So dangers and signs. Again, this slide, I do like to tell the public about dangers of eating disorder, death obviously being the last possible thing that could happen. With you guys, it's a bit more important for you guys to know because the eating disorder really does affect every single organ of the body. And drawing on however much you've learned so far in your education, you know that if you have decreased supply of glucose, the body just goes into a state of craziness. So whether that be hypoglycemia, the patient feels dizzy, the patient feels weak, but eventually if there's no glucose, the body is going to start eating away at whatever it possibly can to make glucose. So the liver depletes itself of glycogen. Once you have no more glycogen, the body needs to find some source of energy. So it goes to protein. And it'll go, to the little protein stores, whether that be, in muscle or the liver. But after that, it's going to start to attack all the other essential muscles. And soon, the person is just going to get emaciated, which is the typical image, unfortunately, that we see on posters for eating disorders. Again, not every patient looks like that, but the thing to keep in mind is that if we don't stop it somewhere, that's what it's going to get. And then when you think about all the other organs, you can see why someone will most definitely die. I had kidney failure. So why? If the body is dehydrated, what happens to the kidneys? They're not getting enough blood. If they're not getting enough blood, they're not making urine output. If they're not making urine output, the toxins are not being removed. Toxins are not being removed, they accumulate. What gets damaged? The liver. What gets damaged more? The kidneys. So do you see, and if the kidneys fail, what happens to the body? Renal shutdown, eventually death. So when you think about it from a medical perspective, you can really see why eating disorders are so dangerous. So obviously lack of nutritional intake, which is what leads to really the sequela of events. And eventually, if no treatment, death occurs. So obviously solution, prevention, identification, and treatment. And obviously you're not going to scare patients and tell them, if you're so dehydrated, your kidneys are going to shut down and we're going to need to dialyze you. No, but helping them understand that, you can't go on like this because your body does need food, needs a variety of food and moderation of everything in order to continue functioning. So treatment. Interprofessional team is just the way to go. We obviously need doctors, we need them to diagnose, we need them to set up treatments, we need nurses, we need the therapeutic communication, we might need social work, we might need therapy, we might need a dietitian, we might need a nutritionist. So understanding that, just like any other patient, rarely can just one healthcare provider provide all the treatment and then they'll be good to go. We need to work with everyone we can, including the family and the patient. We're not forcing patients into treatment, but the important thing to think about, just like with a lot of mental health issues or even some medical issues, patients might not always want treatment. They might not always want to accept treatment. And for eating disorders, it becomes a fine line of where do I force someone into treatment because they're going to die, and where do I let them kind of take the wheel and help them along the way. When I was sick, I thought my parents were the worst parents in the world for forcing me to go to the hospital and forcing me to eat and get well. But I realize now that if they hadn't done that, I would have died. So remember that we're not forcing patients into treatment, we're just helping them until they can help themselves, which is sometimes the case with anything. So, I don't know, if someone has asthma and they totally hate their bronchodilator and steroid because their steroid gives them a funny taste after they put it in their mouth, but you encourage them and you say, no, you have to take it, rinse your mouth after, chew gum, have a cookie, anything like that. They might be like, well, I kind of don't like this, but okay, I'll do it. And that's the same thing with patients with eating disorders. So monitoring their response to treatment. This is probably beyond what you need to know now. But obviously, what are some things that you would monitor in a patient with an eating disorder? Just shout it out.
Weight.
Yeah, weight, obviously. So weighing, before eating, after voiding, in the same clothes, really opening your weight that they could water load, which is drinking excessive amounts before they weigh. A lot of patients, believe it or not, if you weigh them like just in their, say for a female in the bra and the underwear, they will stick objects in their bra and in their underwear to make sure that the weight looks falsely elevated. So hospital gown is probably the best way to go. If you're in a community setting, then just the same clothes all the time and just, be aware. A lot of, a good practice is to just have them kind of jump up and down because, for a female, you can only move around so much there. If you have a rock, it will obviously probably move out of place. And if anyone's hiding any weights or anything, you'll be able to hear it clunk. And just tell them, it's not that I don't trust you, I just want to keep you safe. And they'll probably scowl at you, but you are keeping them safe. What else other than weight?
Overnight heart rate.
Yeah, so bradycardia is a definite big problem with patients with eating disorders. Heart is not getting enough energy, heart starts to slow down, and eventually if it gets too low, they're going to be symptomatic, they're going to have sinus scope, they're going to get dizzy, so obviously heart rate. What about if we're just trying to diagnose someone with an eating disorder? Thyroid, right? Like we might attribute excessive weight loss to thyroid, so we'll do a T4, T3 panel. For females, we might do a hormone panel, FSH, LH, estrogen, progesterone to see the hormonal cycle. We honestly just do a CBC, like just do complete everything. Look at renal function, look at BUN, look at creatinine, look at liver function. That's all I can think of on the top of my head, but I guess it's like you can even look at the muscular activity like CK, or is their muscle being broken down? Sometimes if patients are exercising excessively and they're like really overdoing it, you're going to see an increase in the CK because their muscles are being broken down. So I'm a nerd, and I think that looking at the blood values is really good because it helps you kind of get an overall idea of what's happening with the patient. However, someone with anorexia, for example, might have low thyroid because their body is just not producing enough, so it's starting to slow down because the body selectively chooses what it stops working on as less nutrition is going in. So usually the first thing to go is the menstruation cycle because that's not essential for living. After that, the thyroid might go because, again, it's not essential for living. But just because someone with anorexia has low thyroid doesn't mean we're going to start them on Synthroid because probably the thyroid is a result of the excessive weight loss. So just trying to put all the pieces together. So resistance, like I mentioned before, they're going to be resistant to treatment. And the main point that I want you to get across is we're not forcing them into treatment. We're helping them until they can help themselves. Patients probably won't like that you're saying that to them, but it really is important because it's so hard to admit to having an eating disorder. It's very difficult to accept that type of treatment, especially when they're being forced to do something that they obviously don't want to do. So I often tell people, imagine the thing that you're most scared of, whether that be spiders, snakes, heights. Now imagine being exposed to that thing literally 5 or 6 times a day. Now if you can imagine, if you're scared of heights and someone puts you 5 or 6 times a day on a mountain and tells you to look down, you're going to have palpitations, you're going to hate the world, you're going to hate anyone who tells you to go on that cliff again. And that's what happens with someone with an eating disorder. 5 or 6 times a day a meal. Someone is telling them, I know you really don't want to eat, but you have to eat. And they are going to be ticked off, and they're not going to like it. And for a long time, they're probably not going to see it. But really, when patients with eating disorders do get better, in my case, when I recovered and when I got a lot stronger, I realized that everything my parents did for me, they saved my life. And everything that I really didn't want to do is what kept me alive and is what's making me be well today. So they might not be the most friendly patients. Now that's not to say when you get somebody with an eating disorder, you have to expect resistance right away and expect them to be the most horrible person in the world, but that'll make you be more empathetic to them. If they're showing resistance, if they're showing being a difficult patient and resisting treatment, just to be aware that that's what's going on. Can't we just all get along, move on tea? So it's difficult. It might be difficult to get along with them, but not always. So recovery, the pair. Recovery, mental health, physical health, everything makes a great pair, a great triad. So the important part about remembering recovery is it does mean a healthy weight. Healthy weight being individualized to each patient. Like I mentioned at the beginning, BMI can help you, but it's not an accurate indicator. So just be aware. Obviously, if someone is like a BMI of 13, they might be recovered mentally, although probably not. But just keep that in mind. A lot of the times, the physical and mental health go together. So a patient with an eating disorder usually will start to show signs of emotional and mental health when their body weight goes up and when they're able to regularize their meals. No restriction, no purging. Obviously, mistakes happen, relapses, and little blips along the way happen, but the general pattern should be that they're able to do this. That doesn't always mean that they're able to do it by themselves. A patient might be recovered physically if their weight is fine, but maybe they still need someone to sit with them while they're eating, and that's okay. You will support them along the way. You find someone that can support them during their meals or monitoring them after their meals for purging. And like I said here, recognize signs of relapse. It's important to remember that a relapse does not mean, oh my gosh, that's it, we have to start from square one, which is the same thing with all patients with any medical issue. A relapse is a mistake. It's an opportunity for the patient and for you to realize what went wrong. So for example, let's say a patient, had a test, so they weren't able to eat during that test. And the next time when they come to eat dinner, they get that feeling and they're like, wow, it felt good not to eat lunch during that test. I'll just skip dinner today and I'll start fresh all over again. No. We can't do that. With patients with an eating disorder, you have to be on the ball. If it's 12 o'clock and it's time for lunch, it's 12 o'clock and it's time for lunch. Get a note, eat during your test. Because what we find with patients with eating disorder is even just one skipped meal can be an opportunity for the eating disorder to sneak back in. And then it also plays out with their body, right? Like if their body is used to getting nutrition at certain time periods and they're recovering, and then one meal we suddenly don't do anything, drop in glucose, they get a little wonky, and problems start to happen. So just being consistent with that. But reminding them, and remembering yourself, that a mistake or a relapse does not mean we're starting back from square one. Next slide. Okay, so just a key point to remember, they're mental health issues, they're serious. Weight and BMI is not the end-all be-all. Use the SCOFF tool if it helps. There are so many resources out there. Just be mindful of what you're looking at to help you. There's good guidelines on hospitalization criteria, on what should be the outpatient criteria if somebody needs medical monitoring, what type of tests you can run. So educate yourself, educate your peers, your co-workers. I'm really passionate about this topic. I'm passionate about nursing and medicine in general, but I think that there's a real gap with mental health services and identification and treatment in general, and if we can reframe the way society thinks about it, I think we'll do a great job in raising awareness for it. So these are some good resources. This is my book, which is the best resource ever. But really it is, it's hilarious. There's lots of food puns. I'm hilarious, right? Okay, so the National Eating Disorder Information Centre of Canada, NEDIC, great. They have a lot of good information. I'm a guest post blogger on their blog all the time, and I think it really opens society's eyes to these different types of issues. There's also NEDA, which is the National Eating Disorder Association. FEAST is a great resource, Families Empowered Again for Eating Disorder Treatment. There's also a forum that they have, which is when families can log on and just ask questions. Again, you can refer families to this, just be mindful that there's no really healthcare professionals on that blog, on that forum, so it is parents speaking to each other, but still really